I'm very happy to welcome Tom Liberti. Tom currently serves as the Chief of the Bureau of HIV/AIDS and Division of Disease Control within the Florida Department of Health. Mr. Liberti has served the state of Florida in the public health arena since 1974, beginning his public health career with the STD programs in Dade and Monroe counties. During the 1980s, Mr. Liberti was the STD and AIDS Regional Director for Tampa Bay. In 1990, he moved to Tallahassee to work with the AIDS program, and in January '97, he was appointed the Chief of the Bureau of HIV/AIDS. He has worked very closely with other public health officials and community representatives to design and implement effective HIV prevention programs, and as a result of his leadership qualities, he has developed one of the nation's most comprehensive programs for HIV/AIDS surveillance, education, prevention, early intervention, counseling, testing, care, and treatment. And I might add, he has been very, very busy lately with all the issues going on here in Florida, and I just give him all my respect. So please welcome him.
I don't know what's harder, working this mic or working in Tallahassee. So I'm going to try it for a while, see how far we get. Well, good evening, everybody. It's a joy to be here among friends and family and leaders. And leadership is gone. Let me start off by thanking Butch McKay. Butch McKay, come on, Butch. I'm also kind of sad that Martin Delaney's not here. Martin Delaney was a powerful man who did a lot for people with AIDS in this country, and we've missed him now for 2 years, and I just wanted to spend some time on that. Ladies and gentlemen, these are very difficult times. So I want to thank everyone in the room and who's visiting this part of the state, our friends from Georgia, our friends from Alabama, Mississippi, Louisiana, and quite frankly all over the country, for helping us in Florida over the last year through some of the most difficult times anyone has ever had to deal with. Let me go through my slides and then we'll say a few words at the end. My purpose tonight is to give you a brief update on AIDS in Florida, talk a little bit about the ADAP program, and then some challenges we all face for 2011 and 2012. Well, here we go with the third largest state in the country for HIV. Over 121,000 cases of AIDS, 1,500 cases of pediatric AIDS, 46 more thousand cases of HIV. We now are approaching 100,000 Floridians living with HIV and AIDS in our great state. And we've just increased our prevalence number. That's the number of people we believe are infected that know their status and those that do not know their status. I'm coming in and out, right? I'm going to scream then. It would be remiss of me not to mention disparities. Our state, like many states in the South, are disproportionately impacted in the African American community, and we can all do better. 54% of our AIDS cases are African American or black, and 48% HIV cases, and our population of African Americans or black are only 15%. This is a great disparity, and we can all do better. I don't want to leave out our Hispanic colleagues because we got some very good news that keeps showing up in our Hispanic numbers related to testing, but it's not as severe a disparity, but it's still a raging epidemic, especially in South Florida, among Hispanic individuals. Go to the next. Next. Oh, stay away from the speaker.
Those speakers are turned off. They're turned off. They're turned off. They're not affecting you.
I did want to bring some very good news for people living with AIDS in our state. Let me explain this slide very quickly. In 1995, 4,336 people died of HIV/AIDS in the state of Florida. As many of you know, those are the times when we did not have combination therapy. And shortly after that, protease inhibitors and combination therapy came about. ADAP programs greatly expanded in the United States. Congress allocated $100 million increases, and look at the results. The number of people who died in our state went down and down and down. And in 1998, it went down to 1,547 individuals. Now, don't get me wrong, that's still too many, but progress was made. And for about a 10-year period, we stayed even with the number of people who died at about 1,700. And then I'm very happy to talk about the last 3 years. A number of people who work in Florida in this room expanded their programs, enhanced counseling and testing, enhanced linkage, produced adherence programs, and we saw some results that we were looking for. We saw the first decline in the number of people who died in 2007 at 13%. The following year we saw another 7%, and the 2009, which is the year we have the most recent data, another 13%. We're down to 1,232 individuals. We can go better. We're actually, our 2010 preliminary numbers show another decrease in the number of people who die in our state. Now, why is this so important? Of course, it's an individual and a public health benefit. But this is why when we fight for ADAP, and this is why when we fight for people to get their medicine, why it is so important, because people are living longer, living healthier, and just doing a wonderful job of getting back to work and whatever their life pleasures are. Next slide. Florida, as many of you know, and my friends in Georgia and South Carolina, Louisiana, and the states in the South, help lead the nation in the number of people tested. This slide is actually just a few weeks old, and what it's going to say in just a few more weeks when we update it is that we set the all-time record in the state of Florida with 410,000 tests done in our state. 410,000 tests, not 394. Health departments, community-based organizations, community health centers, jails, clinics, back of pharmacies, mobile units, and close to half of the tests, over half of the tests, are rapid tests. So we're at over 400,000. Why? Because we believe that knowing your status is critical for one's health. Next slide. I want to talk about a couple of programs quickly. Florida's AIDS Insurance Continuation Program was capped about 18 months ago. Why? Because the economy tanked. Unemployment went up. Mortgage foreclosures. All the pieces of the puzzle that relate to the downturn in the economy hurt HIV patients nationwide. And the South got hit hard. And our state got hit hard. Unemployment peaked at 12.3% 2 years ago. And what progress has we made? This week we announced that unemployment was down to 11.9. We just simply haven't gone down. Not enough to help people. There's 1.1 million Floridians out of work and unemployed. And the programs that we manage and we fund are overwhelmed. And this is one of them. Next slide. This is the wait list for the AIDS Insurance Continuation Program. And if you go back in time, it follows the recession or the downturn in the economy. And after September of 2010, we are pleased to say that 150 people were taken off the wait list and given health care benefits through this program. Let's talk just another minute of what you all have to deal with every day, what we have to deal with in the state in trying to provide the funding for programs. The ongoing recession has been described in a number of ways. It's the longest. It has caused more people to be unemployed in the 4 years of this recession than in the last 4 recessions in the state of Florida combined. That's how deep and severe. In the meantime, from the federal standpoint, funding has remained exactly the same, and more people are coming for services. If I had a Medicaid slide up here, if I had a food stamp slide up here, you would see all-time records. Why? Because people were unemployed, are in trouble, and need help. Our programs are no different, folks. General revenue is the money that comes from a legislature in Georgia, in Florida, in Alabama. And if you go look there, there was very little help. Around the United States, there was some. I can single out North Carolina. Their legislature did increase some money for the AIDS Drug Assistance Program. In California, that was true. But in many states, there was no help or little help from general revenue. We had the AIDS insurance wait list, and then we had the great expansion of counseling and testing in this country. Remember 2006, the CDC guidelines, routine testing? Well, we're going to find more people. And some of those people are not going to be insured. They're going to need help. Where is the money for the help? There was also a change in the NIH guidelines. A lot of people missed this one. But NIH guidelines kind of recommended, not strongly, but recommended that it was okay for people to start their HIV treatment at 500 CD4 count instead of 350. And that had an impact on providers and patients in the United States, including in the South. There's always an increase in drug costs, one way or the other. Look where we're standing. In a state like this, on top of the recession, we had the largest oil spill in the history of the United States. That had an effect on business. It had an effect on people's jobs. And we're very close to where it happened. There were other crises in our state. And at the end of the day, there was an increase in demand for services, especially in the South. This is just a slide that demonstrates some of the things that I was talking about. Going back to 2009, the number of people enrolled in ADAP, the number of people that came back in for their recertifications, the number of people needing services, meaning one drug on any given time, ballooned, skyrocketed to over 18,000 patients at its total time. Next. Back. I just want to put this slide because it just demonstrates the red line is the federal money from Washington, D.C. for ADAP in the state of Florida. And it's real easy for me to remember one number. For 3 years of the recession, 83 million, 83 million, 83 million. Okay? And then last year, the year we're actually operating under now, it did go up to 85 million. Now at the same time, patients went up dramatically. And it's getting harder and harder and harder to take care of the same amount of patients or provide the number of services to them with either the same money or less money. And if anyone is running a clinic, I don't have to tell you how hard it is if you have a clinic 5 years ago that had 200 patients, and you run a clinic the next year with 300, and now you go forward and you got 600, and your funding didn't increase, something's got to give. And then the gap that we had in Florida that was well publicized, over 100 newspaper articles. Next. When we're right in the middle of it right now. We told everybody last April 1st, we did not have enough funding to make it to March 31st, 2011. Well, how ironic it is, it's March 12th today. We're close to the finish line, but wow, did we have trouble. And we had trouble because we had let in a sense, 18,000 patients, and we did not have enough money to make it. We calculated some things wrong. We thought the recession would rectify itself much earlier than it did. We thought unemployment would go down sooner. Those assumptions obviously are simply not true. Next. Next. And so what we did was put together pieces. We took our $75+ million of Ryan White money for medications. We had some contracts in Miami for ADAP. We got special money from HRSA. It was called the President's Emergency Money. It's had a couple of names. It was $25 million nationwide. We got $6.9 million. We asked HRSA for supplemental money. We got $2.2. We swept our own budget and got another $1.7 million. We have $9.5 million in general revenue, and we still had about a $15–16 million gap when the time came. Go ahead to the next slide. These are just, again, some of the things that we were doing to close the gap. You can go to the next slide. We actually thought about borrowing money and paying it back. We explored that for several months, and we're basically not allowed to do it. We asked HRSA for special permission to spend money in advance and pay it back, and was denied. And so basically our last resort was to ask the drug companies and Well Vista in South Carolina to take care of our patients, because they qualified for patient assistance program if we didn't have the money. And so we have put together for 60 days a partial one-time system that allows, as of today, for over 11,000 prescriptions coming in the state of Florida to patients all over the state, so there is no interruption in their drugs. Has it been easy? No. Has it been perfect? No. Have people fallen through the cracks? Yes. And hopefully, on April 1st, if we get our grant award, and if the money starts flowing again, all the ADAP clients will be okay. We will be able to purchase large quantities of pharmaceuticals again. Keep in mind, we're purchasing over $8 million a month to keep the program going. This was a wonderful partnership, as painful as it was. It required the pharmaceutical industry, Well Vista, a nonprofit organization in South Carolina. It required the the Fair Pricing Coalition, NASDAQ in DC, to put their heads together, because this was a unique problem with a unique solution. And I thank them very much. Our goal during this crisis was simply for the patient. We did not care about the negative publicity. Our egos, folks, are not that big. What we cared about was the continuation of drugs to our patients in this state, so their viral loads stay down and their CD4s stay up. That was our only goal. Next. Again, just a little bit The projected date for transition started out to be February 1st, 2011. It was a little after that. It was a 60-day or more supply of medicine. A retransition, which we're working on right now, to April 1st. And again, the main objective was a seamless transition, but it's interesting when you're in the middle of something like this, all the unintended consequences. We had to deal with the laws of Florida and the laws with South Carolina as it related to a prescription. And you know, when you're trying to do this on the run, it gets a little tough. These are some of the things that are in the pipeline for after April 1st to make the program more sound. We want to ensure that the 10,000 patients who are on ADAP continue to have drugs. We are realigning our budget, and many of the providers here from Florida know that we've made cuts in other part of our Ryan-wide budget to increase the dollar amount for AIDS drugs. We have to implement a provision on Medicare Part D that will increase revenue to the state of Florida. We have to work on drug rebates through a pharmacy benefits management company. We are begging and yelling and screaming for additional funds from Congress, but many of you read the news like I do, and what they're talking about is decreasing funds and not increasing funds. There's a part of the Ryan White Care Act that we were not eligible for the last 15 years called the ADAP Supplemental. But because we have a waiting list, we are now eligible, and that will bring in additional revenue to our state. And then, of course, it's the partnerships in the big 6 cities in Florida: Miami, Fort Lauderdale, Tampa, Jacksonville, and so on, that will help us pay for more drugs from the Part A. Now, I just want to put up this one slide on the money to illustrate. These are the 4 years of the recession. And this is every dollar that comes into the state of Florida from the Ryan White Care Act. And I'm not going to beat a dead horse. I've already said it 3 times, that we've had our worst recession and everything went up but the money. So what if you could put that back, just. So on the bottom, Part A, as many of you know, is the 6 cities. Part B is the state grant award. Part C is all the individual grant awards. Part D. So in 2007, we had $206 million. In 2008, we had $206 million. In 2009, we had $206 million. And then in 2010, we all did get a little bit from Congress to make it 212. There's no way that anybody could have fought this with those kind of numbers, with no increases, and the demand for service and the high unemployment rate that happened in this state. This is my last slide, and just very quickly, just things to think about during your conference, that as I go around the state and have a meeting up in Washington in 2 weeks, we'll meet with some of our delegation. The ongoing state budget challenges are ongoing. They're very severe in the South. State, our legislature started Tuesday of this week, and they're talking about cutting $3.5 to $4 billion. It's our job to try to protect the HIV dollars. What is where and when will the impact of healthcare reform help public health programs? It's not hitting hard enough and fast enough. The development of the National AIDS Strategy is been worked on for almost a year now, and our provision is going to come out without funding. I'm very worried that I'm a very big advocate of the National AIDS Strategy, but I'm worried that there's going to be recommendations and mandates in this environment with no additional funding. I think the horse left the barn on this one. testing, counseling, linkage, and treatment. This has been called test and treat. This has been called test, link, and care, TLC. But I think this country and our state have embraced the fact that testing people, counseling them, linking them to care, and having treatment available is the model that people want to do in order for personal health and the public health. And again, I'm worried, are the resources, I believe the resources are there on the first two, testing in particular. I'm worried about linkage and I'm worried about treatment, unless something changes. The use of new media and internet-based strategies is exploding. Social media, what is our role? How do we get information to patients, to the public, in all the venues that are from Facebook and Twitter and beyond, when of course there hasn't been any additional funding for those kind of initiatives. The stovepipe program probably has to come to an end over the next couple of years. People in this climate are wanting not to deal with individual programs. They want to deal with holistic approaches. People that have medical homes and talk about their HIV care, their hepatitis care, their STD care, their diabetes, kind of in a one-stop shopping. And unfortunately, the funding comes down categorical, and it's hard sometimes to integrate. We have a major state and a federal and local HIV/AIDS force challenge, because many of the leaders in this country are aging along with the patients and are going to be leaving. I mean, people like Tony Fauci has been around for 30 years. As we approach the 30-year anniversary, people who have run major national organizations whose leadership is unshakable are going to eventually leave. Where is the pipeline of young, dynamic leaders to take their place? I get worried about that sometimes. And then finally, many of you have read up on PrEP, a treatment to high-risk MSM in particular, that has some major scientific findings that can prevent HIV if taken properly. Do we have the will to do that? Do we have the policies yet? Do we have the money? Who's going to pay? Are insurance companies going to pay for PrEP? For high-risk high-risk MSMs? I don't think so. Is there going to be a government pot of money for that? I don't think so. In this environment? So it's interesting that we're reaching a little crescendo here where we actually may have a scientific medical breakthrough and not have the will or the money to implement it in the way it needs to be implemented. And I left off things like needle exchange, behavioral interventions. These are very rough times that we have to deal with these policy changes, both at the federal and the state and the local level. Let me sum up by saying, one, thank you all for being here. You are we are really operating in tough times. Remember that old saying, when the going gets tough, the tough get going? Wow. It is very, very, we're here, folks. So I ask you to do one thing, or two. One, lead by passion and purpose. Keep hope alive, and never, ever, ever give up. Thank you.
Thank you. Thank you, Tom. Thank you, Dr. Hagan. for both having inspirational messages.